Good afternoon, really. I'm so happy to be here. I thank you very much for inviting me to talk to you this afternoon. The assigned topic that I was given was Mo Health Net, our reformed Medicaid or transformed Medicaid healthcare program. Before I do that, let me just say a few words about the Missouri Budget Project. I think some of my colleagues might have already spoken to this group. I know Karen McBee was here. Missouri Budget Project is a not-for-profit public interest organization, and our mission is to analyze the fiscal choices that the state makes, how it takes in money, and then how we use that money, and whether that money reflects the priorities that we feel support the common good. So we've been very involved in healthcare issues because healthcare is a growing concern for every Missourian, but I think it's especially a concern for low-income Missourians, elderly, and people with disabilities who lack health insurance. So just a bit about my background. I was actually a teacher originally, a chemistry teacher. And so it's really hard for me to be behind a podium and speak because I want to be walking around. But and then I traded the classroom for social work, and I worked primarily with low-income families. And that's how I got involved in advocacy, because I saw immediately as I started my work with those families how public policy impacted their opportunities. And I wanted to make sure that there was a level playing field so everyone really had an opportunity to succeed. And that had eventually led me to a job with Citizens for Missouri's Children for about 12 years, and I've been with the Missouri Budget Project now for 2 years. I guess I'd like to preface my remarks about Mo Health Net with just a couple of words about how we got there. How did we get to a place that we found ourselves in last year? And I think to really understand what happened, we have to go back fiscally in fiscal issues to the mid-1990s. And at that time, you're all aware, I know that it's wonderful to speak to an informed audience, but you know about the Hancock Amendment, what that means, how it doesn't allow revenue to grow. And then in the mid-90s, we actually reached that Hancock Amendment a number of times, and money was returned to Missourians. And the people in the legislature, I think it was a bipartisan effort, recognized that we were going to be keeping, we were in a position of having to return money to Missourians. So instead of doing that, people suggested a number of tax cuts. And I was a cheerleader for some of those tax cuts, like the sales tax on food. And so we changed sales tax policy. We enacted at least a dozen tax credits that take money right off the top of our general revenue. And we changed our personal income tax deductions and so got our revenue low enough so we wouldn't reach the Hancock Amendment. Then, having done that, in the late 1990s and early 2000, when the economy went sour, we suddenly found ourselves without adequate revenue to fund what the basic services that Missourians need, things like transportation and infrastructure, higher education, elementary, secondary education, and health care. And first Governor Holden and then Governor Blunt faced some really hard decisions about what to do. And I want to really be very clear that we had an array of decisions that no one was willing to put on the table. And those decisions would have been to raise revenue, to change our tax structure either for corporations or for individuals in such a way that we would generate adequate revenue to fund those basic services. However, that was not happened, and the entire focus was on cutting expenditures to balance the budget. And Governor Holden did a lot of things that were really hard. We used our tobacco settlement money, we swept funds, we actually cut some important programs, and that continued through the next year. And when Governor Blunt took office, he found himself still with a very large deficit and no way to solve that without raising taxes. So his top priority, he said, and his actions followed that, was elementary and secondary education. Deep cuts were made in higher ed, cuts were made in mental health services, and then massive cuts were made in Medicaid, our health insurance for low-income Missourians. That happened in 2005. In 2006, there were lots of hearings that were held across the state. We heard, and I sat with Bob Hund at many of these hearings, and he has testified eloquently about the impact of those cuts on Missourians and the need to change that policy. And basically that fell on deaf ears in 2006. The Medicaid Reform Commission was formed. They developed a set of recommendations that they gave to the governor, and then from that, we had last year our Medicaid transformation bill, Senate Bill 577, sponsored by Senator Shields. And I have to say, in no way does Missouri Budget Project think we can call what happened with Mo Health Net and Senate Bill 577 Medicaid reform. I think of all kinds of analogies, but maybe the best one is we have people in a building and living in a building. Everybody has their apartment. So we put a third of those people out and we remodel the building and make bigger apartments with more amenities and give it to the people who are still in the building. And the people who are made homeless are still homeless. So for them, this is no reform. I think it's hard to talk about, it's a little hard to talk about the changes with people who are proposing them, because they talk about things that I think all of us believe are important. Emphasis on wellness, on prevention, on living healthy lifestyles, on having care that's coordinated so it's efficient and effective. I don't think any of us would argue that those are good goals for a healthcare system. However, the Missouri Budget Project believes you cannot just focus on that and pretend that the more than 100,000 people who lost their health insurance as a result of the cuts don't exist. Those people are very real, and those cuts made very difficult, have made their lives very difficult, made people have to make very hard choices about paying for their health care and paying for their basic human needs, rent, utilities, and their medicines. So, that's kind of how we got here. And I'll run down briefly the main provisions of Mo Health Net, and then I do want to allow some time for questions, because it's a very complicated system, and there's much actually that still remains to be decided. This bill, Senate Bill 577, created a lot of additional bureaucracy and left many important decisions that will be decided by groups that have yet to be appointed, by commissions and committees. So we don't know the entire picture. So what Mo Health Net did some good things. And these are things that people that supported will tout as addressing the cuts that were made in 2005. I think the group that gained the most from Mo Health Net were children. Our state has a Medicaid program and then a state children's health insurance program called MC Plus for Kids that allows families with incomes up to 300% of federal poverty level to have their kids insured through CHIP, as long as they don't have access to employer-sponsored insurance and they pay premiums. In 2005, the changes that were made were not intended to affect children, but in fact they did. Tens of thousands of children fell off the CHIP rolls. And part of that was because of an affordability test. The affordability test was set at a portion of the Missouri Consolidated Health Plan cost for children. And when they set it, they didn't consider the employee portion, but the whole cost of the health insurance. So if parents making $20,000 had access to employer-sponsored insurance for their child that cost about $340, then they wouldn't be eligible for CHIP. Now, common sense would tell you somebody that's making $20,000 a year cannot afford $340 a month just for insurance policy for their kids. So that was a real hardship. And people recognized that early on, but because of political infighting among the party that was in power in 2006, nothing happened, even though the legislation was there to fix that. However, in 2007, that was fixed, and that would affect about 6,000 kids, the fix that they did. It does not address all the kids that fell off CHIP, but it will help about 6,000 people. There were a couple of other changes that were really good. If a child has a medical condition that's not covered by employer-sponsored insurance, and they would otherwise be eligible for CHIP, then they're eligible. Or if a child has exhausted the benefits of private employer-sponsored insurance, they're allowed to be eligible for CHIP. So those are good things, and estimates are that would probably affect about 3,000 more kids. The other group of young people that were helped were youth who were aging out of foster care. And these are kids who really face a tough time. When they leave foster care, many of them do not have the family support that most young adults in their early 20s have. I mean, I have two kids in their 20s, you know, and I just know that we've been able to help them financially and with health insurance and in many ways. And kids in foster care just don't often have that kind of support. They often, the kids who are aging out of foster care end up in jail, unemployed, as victims of crime, that they are not likely to go on to college, and you know, are just set up to have a difficult time as an adult. So by allowing them to continue to be eligible for Medicaid until they're 21 is a real positive. Because that way, if they're in school or if they're in a low-paying first job, they're not likely to have employer-sponsored insurance, and this would enable them to have the insurance they need. So again, that's a very positive provision of the bill. The other group that was, at least some of whom were assisted or will be assisted in MoHealthNet, are people who have a disability who are able to work. There was a program called MAUD, Medical Assistance for Workers with a Disability. About 17,000 people were insured through that program when it was cut in 2005. The new program that was designed last year as part of MoHealthNet will allow about 3,000 of those people to be insured. And these are people who are able to work but have a disability, and their needs are such that their health needs are usually not covered through private insurance. So that they need some kind of comprehensive insurance, and Medicaid, now MoHealthNet, would provide that. So that was a step in the right direction. Certainly there are many people who will continue to fall through the cracks. There were some populations and things that were completely off the table and we think should not have been. I think the structure of the spend down program, where people who are elderly and people with disabilities have to pay huge premiums each month to pay down their income, so till about $700. And we know from stories that that's a tremendous burden on these individuals. But that was not ever addressed, nor was the general relief program. And that program just went out of everyone's minds when it was ended These are people who have a temporary disability or who have a permanent disability and are waiting to be approved for Social Security disability, or SSI, and are not able to work. They used to get a small cash grant of $80 a month, so that was the first thing that was cut. And then in 2005, all their medical benefits were cut as well. So those are people that continue to fall through the cracks. During the debate of the bill, there was a lot of discussion about physicians and the needs of physicians and other providers. And the bill in the House that handled it was handled by Dr. Rob Shaw. And that was his top priority, was assuring that physicians had better reimbursement for Medicaid services. And I have to say that is a tremendous need. People who provide services through Medicaid, physicians, other doctors, therapists, psychotherapists, social workers, all get a very, very low reimbursement. And we know that it does discourage doctors and other providers from participating in the program, and we have to address that, but to do that is going to be costly. So to do that, there was a committee that was put together that is to develop a plan to do in the future. There is no discussion of how to fund it, but there is that plan. The other part of MoHealthNet that could impact doctors, and we're a little concerned about the impact on patients, would be a pay-for-performance bonus that providers, and it's not clear who the provider would be, but when there are good health outcomes, then a doctor would be paid a higher amount, a higher reimbursement. Our fear is that that could discourage doctors from caring for people who have the highest, most complex health needs. And we're assured that will not happen, but it remains to see how that will be implemented. The other positive thing that I think people talk about this year is restoring some of the services that were cut in 2005. Durable medical equipment, again, is a covered benefit, as well as vision and some dental services for adults. However, the vision and dental services were not funded in the budget. So nothing will happen with that unless there's a supplemental appropriation request when the legislature reconvenes in January, and then that would be funded. But right now, that remains an empty promise. I would say just another concern that we have, in the original MoHealthNet proposal that the Department of Social Services put forward, there were a couple of things that we were very concerned about. One was to have patients earn benefits, that if you stopped smoking or lost weight or did other things that would contribute to a healthy lifestyle, you could earn extra benefits like dental. We think that's a very bad idea. People should never be asked to earn their basic benefits. And a lot of people in the mental health community really spoke out about that too, because some of the psychotropic meds cause folks to gain weight. Some people smoke because it takes the edge off the side effects of their medication, and there's just a lot of problems with that kind of a concept. The other was that there would be a plan of care created for everyone, and then services would be provided based on that plan of care. We would be concerned that if the plan of care isn't adequate or isn't up to date, people might have very real health needs that couldn't be funded. Now, we think those are bad ideas. They were put forward by the Department of Social Services, who now has the responsibility to implement this bill. My most cynical fear would be that they would add those back in through policy and through rules. So I think we have to be very vigilant as this whole rolls out and we really see how the department plans to implement it. Okay, I want to allow plenty of time for questions, so maybe let me stop there and, entertain questions. Yes, Al?
I have a question. If in the unlikely event that the single-payer insurance would come to fruition, how would that affect the people currently on Medicaid?
Okay, the question was, in the unlikely event that we actually adopt a single-payer healthcare system, health insurance system, how would that impact people on Medicaid? I would assume that they would be part of the single-payer system then, that would somehow absorb that. In other states that have made significant efforts to really try to ensure everybody, most haven't used the single-payer concept, but have gone about it kind of piecemeal and actually have beefed up their Medicaid programs. Because people with low incomes, especially working families, the lower your income, the less likely it is that you'll have access to employer-sponsored insurance. So then they did a number of private market reforms, but they were all built on a strong Medicaid program that covered people at least up to 100% of federal poverty level. Missouri now covers elderly and people with disabilities up to 85% of the federal poverty level. And we cover working families to about 18% of federal poverty level. So we are a very long way away from those scenarios.
Just to follow up on questions, it would be more helpful for those of us in the room and the general audience that may be watching this in the future, if you gave us a dollar amount rather than percents, a dollar amount for 1, 2, 3 people, person, families.
Okay, I don't have a dollar amount for one in my head,
Okay.
but I can tell you that a family of 4 at the federal poverty level is $20,000. So a family of 4 would only be eligible for Medicaid. The parents in that family would only be eligible for Medicaid if they made about $340 a month or less.
Thank you.
Yes.
Is there any study or any data that discusses the impact that these changes are having on poor or rural counties that border other states in Missouri in terms of the tax base? Are we seeing taxpayer flight across the border as a result of this? I mean, has anybody looked at that?
The question is, do we see any impact on border counties as a result of these changes? And in Missouri, I do not see that. I live in St. Louis, and quite frankly, I don't understand why there isn't a sucking sound of people leaving for Illinois, because just in terms of their, of quality of life, they just do a better job in Missouri. But that's a very good question, and the evaluation question I think is extremely important. We need to do adequate evaluation of this policy to assure that it's achieving its goals and also that it doesn't have unintended consequences.
I mean, just as a business person, it occurs to me that if you have an issue where you're losing your tax base, and especially in the places where the tax base is the most needful of revenues. The other comment I had was somebody who's in the computer industry. The provisions, the disincentive for providers that you talk about in the computer industry, we call it a metrics matrix. It's a service metrics. It's exactly how businesses function. This is a terrible idea for healthcare, if I could be so bold, simply because of human nature. Doctors are smart and they're human. They will, even though the system assumes, in order for it to work properly, that people won't work the system. Human nature, by definition, takes over. And doctors, just like computer dealers, figure out and work the system for maximum profit. It's not good or evil, it's just the reality. I mean, that's something that, is there a timeline at which the legislature is going to revisit that and go, oh, oops, people aren't as dumb as we thought they were?
Okay, the question is how about, a very long question, but will providers learn how to game the system, basically, because it's human nature. There is some evaluation built into this. It's not clear, again, because none of it is really developed, how that would be evaluated, how it would be done, who will even do it. We don't have adequate...
So the metrics don't even exist yet?
No, not yet. Yes, Chris?
Am I accurate to say that Democrats and liberals and do-gooders caused the deficit that served as the justification for the Medicare cuts.
Okay, the question is, have Democrats and other do-gooders, liberals, caused the deficit that caused the budget
No,
cuts
that was used as the rationale for the Medicare.
that were used as a rationale? I would say in part, I mean, it was
In part, in total.
well, except I think it was,
How do you escape responsibility for those sales tax cuts when they came home to bite you?
no, I'm not saying that. I do assume responsibility, and I was one of the people that, talked up and encouraged the sales tax on food to be cut. However, I think there was some bipartisan work in this. I don't think it lies solely with the Democrats.
They were the majority, they were the governors, they were the pushers of it, and they fixed a temporary problem.
That's
That is
right.
the Hancock refunds with a permanent solution. And then Blunt and his guys did exactly the same thing in this last session.
Yes, that's true. Yes. Okay, I accept blame on behalf of liberals.
And it ain't like it's a new pattern. In the 70s, they did it with bond.
That's
Every
right.
time there is a surplus, the fix is, for a temporary surplus, is a permanent tax cut. The
Exactly.
economy turns around and we get back in this situation.
Exactly. Yes, we do continue to make permanent cuts as temporary fixes. And I have to say, let me just digress a bit, because we're about to begin a special session next week, which will address some of the same kinds of permanent cuts that are being proposed. They're going to have a devastating effect by 2010. I hope all of you have called your legislators and urged them to reject House Bill 327, an economic development bill that, as it stands, it was vetoed, and it would have cost several $100 million. Now it will be scaled back, we believe, but it still has a lot of special interests, and this is a very, very bad time to make permanent tax cuts that will affect our future. Our economic recovery is very tenuous, and we know eventually it is cyclical, and we will be in a deficit again. So these are bad ideas. We need to ask them to just say no.
Ruth, thank you very much. We really appreciate it.